Because of its misleading name, heartburn is one of the most misunderstood everyday conditions there is. Even though the symptoms of heartburn may resemble those of a heart attack, in reality, heartburn has nothing to do with the heart. Instead of irritation to the heart, it's irritation to the esophagus, which sits behind the trachea and the heart, close to the breastbone. Regurgitated gastric acid from the stomach is the source of this irritation, which is also the main symptom of gastroesophageal reflux disease, as well as indigestion. The symptoms of heartburn include a distinct burning sensation and an acidic taste in the mouth, which may occur after eating or at night. It may also worsen when the person lies down or bends over. For clinical diagnosis, imaging may be required, as chest pain due to GERD closely resembles chest pain caused by cardiac conditions, as both the heart and the esophagus share the same nerve supply. This is just one aspect of the complex structure of the esophagus. The esophageal wall consists of the lumen, or hollow portion, along with layers of mucosa, submucosa, muscle fibers and fibrous tissue, and the outer connective tissue. The mucosa is a protective epithelial layer which secretes mucus to prevent pathogens and dirt from entering the body, and is supported by the submucosa, which helps it adhere to the muscular layer. Epithelium is one of the 4 basic tissue types, the other being connective tissue, muscle tissue, and nervous tissue. Epithelial tissue is classified depending on its layering and cell structure, and different combinations are found in various areas of the body where they have specialized functions. In terms of layering, stratified refers to a multiple layered structure, whereas simple indicates a single layer. Then, there is the structure. Squamous cells are flat and cell-like compared with the more regular cuboidal and columnar cell structures. The esophagus consists of stratified squamous epithelium, which protects against abrasion just like the mouth, whereas the stomach contains simple columnar epithelium, which absorbs and secretes mucus and enzymes. Although a weakened esophagus may contribute to or promote GERD, the single leading cause is the malfunction of the lower esophageal sphincter. Sphincters are a group of tissue structures found at orifices or body openings where they maintain constriction as the muscle shortens to prevent the contents, which can be either solids or liquids, from spilling out. These are particularly evident in the digestive system, and there are 2 types of sphincters in the body. Anatomical sphincters contain a distinct thickening in the region which sets them apart from the surrounding tissue. Functional sphincters, on the other hand, do not include a localized thickening, though the existing muscles in the area contract, meaning they act as a sphincter. Sphincters can also be voluntary or involuntary, depending on whether somatic or autonomic nerves supply them. However, the majority are involuntary, and if a sphincter is voluntary, it is usually accompanied by an involuntary one. Examples of sphincters include the lower esophageal sphincter, which is a functional sphincter responsible for preventing acid from the stomach traveling up the esophagus. The upper esophageal sphincter is an anatomical sphincter found at the top of the esophagus, which opens upon the swallowing reflex to allow food to enter with minimal air. Moving downwards through the digestive tract, there is the pyloric sphincter, which is found at the junction of the stomach and the small intestine and is responsible for gastric emptying. The sphincter of Oddi is located where the common bile duct and pancreatic duct meet the duodenum, to control the flow of digestive enzymes from bile and pancreatic juice into the small intestine as we digest food. Moving downwards still, there is the ileocecal sphincter, located in between the ileum of the small intestine and the colon, where it prevents reflux of colonic contents back into the small intestine. An example of a voluntary sphincter includes the anal sphincter. This is the end point of the digestive tract next to the rectum, where it is responsible for the evacuation of feces and contains both an involuntary inner component and a voluntary outer component. The urethral sphincter controls urination with a similar 2-component structure to the anal sphincter. It is found in slightly different places and with slightly different functions in males and females. To give an example of a sphincter not located in the gastrointestinal system, there is the pupillary sphincter, which controls pupil dilation and constriction to allow varying quantities of light into the eye involuntarily. These are just a few examples of some sphincters, though they are located at the end of almost every hollow muscular structure in the body. Improper functions of these sphincters can lead to a whole host of similar conditions. For example, the malfunction of the lower esophageal sphincter leads to GERD, anal sphincter leads to fecal incontinence, and urethral sphincter causes urinary retention. Along with sphincter issues, the other leading contributor to acid reflux is the gastric acid itself. secreted by the parietal cells in the gastric glands. With around 1.5 litres per day being produced, it mainly constitutes of hydrochloric acid, potassium chloride, and sodium chloride. These glands are found in the fundus or upper curved part of the stomach, as well as the cardia, which is where the esophageal contents empty into the stomach, where they secrete chloride and hydrogen ions. These glands contain a network of canaliculi, which are channels in the parietal cells which increase the surface area for secretion and secrete substances into the stomach lumen. Moreover, the number of canaliculi on the parietal cell membrane can increase or decrease depending on secretory need. The stages of gastric acid secretion can be categorized into production, regulation, and secretion. During production, firstly, carbonic anhydrase catalyzes the reaction between carbon dioxide and water to produce carbonic acid in the cytoplasm of the parietal cells. This then dissociates to produce hydrogen and bicarbonate ions. This bicarbonate ion is exchanged for a chloride ion and diffuses into the venous blood. Then, potassium, sodium, and chloride ions diffuse into the canaliculi, where the hydrogen ions within the cell are exchanged for excess potassium ions and hydrochloric acid is formed in the canaliculi. This active transport gradient between the H+ and K+ ions is roughly 3 million to 1 and is thus the steepest anywhere in the body. Finally, some sodium ions are reabsorbed back into the cytoplasm. Gastric acid secretion is predominantly triggered by histamines, the parasympathetic neurotransmitter acetylcholine released by nerve endings in the stomach, and the hormone gastrin. Somatostatin inhibits histamine production among other hormones and thus reduces secretion. The actual secretion of gastric acid in response to eating occurs in 3 distinct phases. Firstly, there is the cephalic phase, which accounts for roughly 30% of secretion. The anticipation of eating causes the vagus nerve to activate parietal cells, activate ECL cells in the gastric glands to release histamine, activate G cells in the pyloric glands to release gastrin, and inhibit D cells which release somatostatin. The gastric phase accounts for 60% of secretion and occurs when the distension of the stomach and amino acids from food trigger acid secretion. Finally, there is the intestinal phase, responsible for the remaining 10%, in which the distension of the small intestine with chyme triggers acid secretion. One common misconception is that the acidity of this fluid is primarily to kill bacteria and pathogens, when actually, the primary function of the stomach acid is to aid the formation of digestive enzymes. Firstly, the acidic environment causes the proteins in food to denature and expose their peptide bonds. The gastric acid then reacts with pepsinogen, secreted by gastric chief cells to form the protease pepsin, which breaks down the proteins by breaking these bonds in a process called proteolysis. This food leaves the stomach as an acidic semi-liquid called chyme, which is then neutralized by pancreatic juices, which travel through the pancreatic duct to the duodenum. Next, let's specifically talk about gastroesophageal reflux disease, or GERD as it is otherwise known. GERD is caused by the inadequate closure of the lower esophageal sphincter, which separates the stomach from the esophagus as previously mentioned. This inadequacy may be a result of the LES relaxing at inappropriate times, being weak, or otherwise compromised. As a result, backflow or reflux of gastric acid and stomach contents causes heartburn in the esophagus, which is far more sensitive to acid than the stomach, also causing severe damage to the esophageal mucosa. Other symptoms include bad breath, a sour taste in the mouth, or a feeling of a lump in the throat. This damage also makes the esophagus more vulnerable to infection, as well as esophageal cancer. Risk factors include obesity, pregnancy, smoking, hiatal hernia, and certain medications such as bone strengthening drugs, blood pressure drugs, aspirin, sleeping pills, iron supplements, and certain antibiotics. Other physiological factors include stomach distension, delayed gastric emptying, or excess stomach acid. Obesity and pregnancy cause excess fat or weight to induce pressure changes in the stomach, which affect lower esophageal sphincter function. Smoking irritates the lining of the esophagus, meaning it is more vulnerable to heartburn, and nicotine causes the lower esophageal sphincter to relax excessively. Hiatal hernia is when the stomach moves into the chest area above the diaphragm, which is common in pregnant women as the fetus pushes the abdominal organs upwards. Diaphragmatic problems may also cause acid reflux, as this organ separates the chest from the abdomen, and thus the esophagus from the stomach. This excessive acid in the esophagus can cause complications such as ulcers, which may bleed, along with stricture, where the esophagus narrows due to scarring. In terms of the treatment to GERD, there are 3 available treatment options after diagnosis or even for prevention. The first of these are lifestyle changes, which are the first step for overall prevention. This includes losing weight, stopping smoking, and avoiding certain foods such as coffee, alcohol, fatty foods, acidic foods, and spicy foods. The second treatment option is over-the-counter and prescription medications. Short-term over-the-counter treatments are usually either antacids or alginic acids. Antacids neutralize excess acid in the stomach and esophagus, thus decreasing the total amount of acid. However, they act as short-term symptom relief that isn't as effective as prescription medications. Alginic acids are an OTC medication which forms a protective foam barrier to acid reflux, a prominent example including Gaviscon. Alginic acids and antacids provide the most rapid relief, while the other medications provide sustained relief in anticipation of a specific trigger. Moreover, these OTC medications are only temporary and don't allow the injured esophagus to heal. Long-term prescription treatments can be categorized into proton pump inhibitors and H2 receptor blockers. Proton pump inhibitors decrease stomach acid production by inhibiting the enzyme which exchanges potassium ions for hydrogen ions. They provide incredibly effective long-term relief, and most are just as effective as each other. Omeprazole is one of the most common prescription medications in the world and listed on the World Health Organization list of the 40 most essential medicines. H2 receptor blockers decrease stomach acid production by blocking the action of histamines. This means that they are a type of antihistamine, though the term antihistamine usually refers to H1 receptor blockers which treat allergic reactions. Low doses of these are available over the counter, though more effective doses require a prescription. For those who don't find proton pump inhibitors helpful and where other medical therapies have failed, a surgical procedure known as a Nissen fundoplication may be necessary to provide long-term relief from GERD and hiatal hernia. While all of the medications used target GERD by decreasing acid production, this surgery instead strengthens the LES. In the procedure, the fundus of the stomach is wrapped and stapled 360 degrees around the LES. Partial fundoplication is also used to treat other conditions and minimize complications such as gas bloat syndrome and dysphagia or trouble swallowing. However, when heartburn hits, there are many remedies and treatments which can provide relief, and surgery is only needed rarely. Despite this, lifestyle changes are still the #1 way of alleviating heartburn, so get out there, exercise regularly and eat healthily, and you shouldn't have anything to worry about.